Okay, well, let's go ahead and get started here. Welcome back to class. And we are going to take a look at the appendicular skeleton today. The bones of the arms and legs and hands and feet, and the shoulder girdles and the pelvic girdle, as we call it. So anybody have any questions on anything? Okay, well then I'm going to go ahead and get us started. Let me open up this. You go to the appendicular skeleton. Everybody should see the screen that says appendicular skeleton. And let's see if it opens up this time. Oops. There we go, appendicular skeleton. So we're going to start with the clavicle. The clavicle is our collarbone. It is the bone that sticks out here in the front of our thoracic cavity, thoracic cage. It sort of leads out here. It's easily broken because it's leading out here. The clavicle helps to form a joint between both the top of the sternum and the end of the shoulder. The clavicle has obviously two endings. One end articulates directly on the sternum, and one end articulates directly on the shoulder blade or the scapula. You can see the clavicle here in this animation. You can see where it articulates on the sternum, right on the clavicular notch. Clever name for the clavicle to articulate on the clavicular notch. The other end of the, and that's this thick end down here is, let me carry it away. The sternal end, the thick end of the clavicle, articulates at the clavicular notch on the sternum. The flat end of the scapula, and the scapula has a flat end and a thick end. The flat end is called the acromial end. It's on the lateral side. So if we were looking at this clavicle, we would see that we would say, well, the flat side is the lateral side, the sternal side is the medial side. And if we look at the animation here, we can see that the flat end out here is going to be articulating with a flat structure on the scapula, on the shoulder blade, that looks exactly the same. It's a flat end. It's also called the acromion. So we have the acromion of the scapula and the acromial end of the clavicle. So, and it helps to form this joint here that, what we call the pectoral girdle, where the shoulder blade and the collarbone and the humerus, the bone of the upper arm, all come together at the shoulder joint. So what we call the pectoral girdle. So the next bone to look at that makes up part of this pectoral girdle is the shoulder blade. You can feel your clavicle. You can put your hands on the front of your chest. You can find where your sternum's located, come up to the left and right sides, and you'll feel your clavicle across here, your collarbone. And then if you want to see where your scapula, your shoulder blade is, put your hand over your shoulder. Okay? Not at the top of the shoulder, but behind the shoulder. And you'll feel a ridge line there. You'll feel a ridge line on your back. And that is this structure here. This is the spine of your shoulder blade. You can feel the spine on each side by putting your hand over your shoulder. The palm of your hand should be touching the top of your shoulder, and your fingers are going to be on the spine of your shoulder blade, or the scapula. And here we're looking at our scapula right there. So this is our shoulder blade, the scapula. There's a big flat area that we encounter. We can't feel that when we're reaching back to touch our spine. But this is the area directly below the spine. It's the infraspinous fossa. Infra means below. Spine refers to the spine structure. So the fossa is the flat area below the spine, just like the infraorbital foramen, the opening below the orbit. Yeah. So, and I'll give you a hint, if we have an infra, we're going to have a supra. So the infraspinous fossa. Now, it's real important to remember these names, because especially, depending on whatever kind of healthcare you're going into, obviously knowing bones is very important here. But the infraspinous fossa is where we find a muscle located that shares its name. The muscle is called the infraspinatus, the muscle below the spine, infraspinatus. And if you've ever heard the term rotator cuff muscles, the infraspinatus is one of the 4 rotator cuffs. So we'll talk all about them when we get into muscles, shortly after we get done with the bones. Now, infraspinatus sets in the infraspinous fossa. What came first? Well, probably the name of the bone before the muscle. So the infraspinous fossa, that means we're going to have at some point likely a supraspinous fossa. So there's our glenoid cavity. The glenoid cavity is the socket for the shoulder, for the upper arm, the humerus, to fit into that space. It's not much of a socket, but that's good because we want to have an extreme range of motion at our shoulder. We have almost a full 360-degree range of motion already, and we like that. We like to be able to move our arm all the way around. And so there's not much of a socket there. We're held in place. Everything is held in place thanks to ligaments and tendons and the muscles themselves that surround this the shoulder. So, but there's where the head of the humerus is the bone of the upper arm. The bone makes up our shoulder. The head of the humerus completes the triangle of the 3 bones going in to form our shoulder. The head of the humerus fits in the glenoid cavity or glenoid fossa, because it's almost just a flat area. It's not much of a cavity to begin with. There is the spine that you can feel when you put your hand back over your shoulder. Again, palm of your hand on the top of your shoulder, and your fingers are going to be touching your spine. There is a process called the coracoid process, jutting out off of the it's anterior to the glenoid cavity, and then directly above that is the acromion process. The acromion process is a structure that articulates with the clavicle. The acromial end of the clavicle articulates on the acromion process. Now, all of these structures are designed to be points of attachment for muscles. Muscles and connective tissue, ligaments and tendons, that all come together to surround this structure. So the acromion process is a flat structure. It articulates with the clavicle at the acromial end, the flat end of the clavicle. The coracoid process just sort of hangs there and muscles attached to it. Now, this is the vertebral border of the scapula. This is the side closest to the vertebrae, because now remember that the scapula, the shoulder blade, sits on top of our ribs. It's not embedded in the thoracic cavity. It sits on top of our ribs. But even so, this flat border here is the side closest to the vertebrae. We call it the medial border or the vertebral border, and that means this other border out here is going to be the axillary border, the area closest to our axilla, our armpit region, if you will. Axillary refers to the area of the axilla, which is, for want of a better term, our armpit region. It's on the lateral side of this bone. And we have an inferior angle, and whenever we have an inferior angle, we're going to have a superior angle, and that's up here. And we have a superior border, and it doesn't get shown, but there is an inferior border. You don't need to worry about that either. So, okay. Now, there's our glenoid cavity. There's the glenoid cavity right there. There's the spine right there with the acromial, and there's the acromion right there, articulating with the acromial end of the clavicle. This is the clavicle back here, and this is the acromion here. And that's the spine. So the acromion comes, is a continuation of the spine itself. So, and here this is the infraspinous fossa, and this is the supraspinous fossa. Okay. There's the acromion, where it articulates with the acromial end of the clavicle. This is your clavicle back here, actually in front. That's, we're looking forward from this perspective. And this is the this would be the right scapula. This is the vertebral border for it here. This is the axillary border, but there's the medial end, the lateral end. So this is the right scapula. The coracoid process just sort of juts up there off of the glenoid cavity. Doesn't do a whole lot other than its very important role of being a point of attachment for muscles. And of course, you can see the clavicular end, the clavicular notch, and the sternal end of the clavicle here, right where that arrow is. We don't usually have an arrow on our manubrium, but in this case we do. And there's the flat end out there. Now the supraspinous fossa, the flat area above the spine. That's what supraspinous means, above the spine. And fossa is the flat area above the spine. And the muscle that sets in there is called the supraspinatus. That's also one of the rotator cuffs. So if you've heard of rotator cuff muscles or rotator cuff injuries, you see where two of the muscles are located now. One on the infraspinous fossa and one on the supraspinous fossa. They share the same names. We're going to see that a lot as we get into muscles. Another perspective here on our scapula. There's the glenoid cavity. And here, the glenoid cavity, we see the acromion right there coming off of this is the spine, so the acromion forms off of the spine like this. There's the spine right there. The coracoid process, that's coming off of the glenoid cavity. The axillary border or lateral border, there's the spine right there. The infraspinous fossa, the inferior spine, supraspinous notch, supraspinous fossa. This is the fossa. This is very important. This is very important. Your landmarks are going to be the spine and the glenoid cavity and the acromion process. Those are your major landmarks here. The supraspinous fossa, the spine of the scapula, the infraspinous fossa, the glenoid cavity, and the acromion. Those are your major landmarks. Because there's your vertebral border there. Now looking at the underside of the scapula. Now this is the side that rests on top of, this is the side that's resting on top of the ribs in the back. And there is no spine on the underside of the scapula. So you have one great big flat area here called the subscapular fossa. Subscapular fossa, the flat area underneath the scapula, subscapular, underneath the scapula, the fossa, the flat area. And there's a muscle there called the subscapularis. Don't worry about the name of the muscles now, you'll get them later on. But the subscapularis is the third muscle involved in the rotator cuff. There are 4 muscles involved in the rotator cuff. We see their locations here on the bones in 3 places. The supraspinous fossa, the infraspinous fossa, and the subscapular fossa. And the muscles are named for these bones. But this is an area here where it's all muscle. So the subscapular fossa, this is what rests on top. This is the surface in contact with, or would be in contact with, the ribs. It's resting on the ribs. Subscapular, suprascapular notch, superior angle, inferior angle, axillary border, vertebral border, coracoid process. Remember, it comes off of the glenoid cavity. There's the acromion, and there's the glenoid cavity. So again, glenoid cavity, acromion, subscapular fossa. Important things to remember. Superior border, and there's an inferior border, which doesn't show up here. Okay, one more time on this. This is looking at it. This is the side that would be pressed up against the ribs, or where the ribs are located. This is the anterior view, because this is the side that faces forward, faces in the anterior direction. The posterior surface of the scapula has the spine. You don't see a spine on this. The spine is on the other side, in this area right in here. So this is the subscapular fossa. Don't worry about that notch. It changes names every time we flip it over. So, superior angle, inferior angle, axillary border, vertebral border. Vertebral border is curved. The axillary border runs straight. Coracoid process, acromion process there, and the glenoid cavity right there. No
more. Okay.
Now, so that's the shoulder blade and the clavicle. They come together and they form 2/3 of the pectoral girdle. Now the remaining third of the pectoral girdle, is formed from the humerus, the bone of the upper arm. And this bone does some pretty interesting things for us here. And not only do we get to rotate around our shoulder, thanks to the humerus, this head of the humerus fits into the glenoid cavity and gives us almost a full 360 degrees of rotation. It also provides the basis of the rotation of our arm at the wrist and at the hand, the ability to open jars and turn doorknobs and use keys and use tools, manipulating our environment, and the ability to bend our arm is thanks to our humerus. So now this structure right here, when we talked about the skull, and I was talking about the occipital condyles, I said there are bones that project, up and down, and those are called condyles. There are bones that project side to side, and those are called epicondyles. And you saw the occipital condyles at the base, on the base of the skull, on either side of the foramen magnum. There were those protrusions that went up and down that the skull uses to sit on top of the atlas. Well, here we have our first epicondyle. It extends out from the side. Now this is the medial epicondyle. How do I know it's the medial epicondyle? Well, because the head of the humerus is always on the medial side of the humerus. No matter which way you turn the humerus, the head's always going to face the medial direction, medial side. So anything lined up with the head is on the medial side. So there's the head of the humerus right there. That makes that the medial epicondyle. And if you have a medial epicondyle, you're going to have a lateral epicondyle. And that's what this is over here. That's the lateral epicondyle. It faces away from the head. So we have the medial and lateral epicondyles. Points of attachment for muscles. That's what that's what we're using all these processes for. We also have this funny looking ridge line here called the trochlea. The trochlea is the ridge next to the medial epicondyle, and the capitulum is the ridge line next to the lateral epicondyle. It's called the capitulum. So we have these four structures here, two of which are going to be very, very important in movement of our lower arm. Medial and lateral epicondyles are there for attachment of muscles. Okay, so moving up to humerus, we have a flat area here called the coronoid fossa. And there's going to be a corresponding flat area on the other side of the bone. We have a bulge about halfway up about in the middle of the humerus called the deltoid tuberosity. A tuberosity is a bulge. That's for want of a better term. We'll see several of these as we go through the rest of the skeleton here. This is the deltoid tuberosity. The deltoid muscle, the muscle in your shoulder, the muscle that you get injections in, the deltoid tuberosity attaches itself. We call it the insertion point. It attaches itself to the humerus at the deltoid tuberosity. Muscles will always have an origin and an insertion. Origins where they start, insertions where they finish. And so the deltoid tuberosity attaches to the deltoid tuberosity is the point of attachment for the deltoid muscle. Now this structure here is called the lesser tubercle. Don't know why they call it that, but that's what they do. The lesser tubercle is butted up right next to the head. The greater tubercle is, well, there's the head, and the greater tubercle is on the other side. The greater tubercle and lesser tubercle, are these little bulges here. They are points of attachment for muscles. In fact, those are usually the points of attachment we consider where some of the rotator cuff muscles attach. We'll talk about that. That's their insertion point on the head of the humerus. That's what rotator cuff muscles do. They all attach on the head of the humerus, and they attach the greater tubercle and the lesser tubercle. We also have this groove in between. There's the head right there. This is the structure that inserts itself in the glenoid cavity. This is the head, and the head is always on the medial surface of the bone. Doesn't matter at all whether you're looking at the anterior view or the posterior view, the head is always on the medial side. So what do we know from this? Well, we know that there's the head. There are these two bumps called the greater and lesser tubercles where rotator cuff muscles will attach. We have the deltoid tuberosity where the deltoid muscle attaches. We have a medial and lateral epicondyle. We have two structures, one named trochlea and one called capitulum. There's your greater tubercle right there. And there's your lesser tubercle next to it. with the groove in the middle. There's the head of the humerus going into the glenoid cavity. Now, if we flip this over and look at the posterior surface, again, there's the head. That's still going to be on the medial side. This bump right here is a deltoid tuberosity, by the way. This depression, this fossa over here, is called the olecranon fossa. If we didn't have an olecranon fossa, our elbow couldn't work. Now, since the head's on the medial side, this is still the medial epicondyle. Because there's the trochlea, there's the medial epicondyle. Up here, we're going to see the capitulum and the lateral epicondyle. There's the lateral epicondyle, and that should be the capitulum. And it went back to the head. Of course it did. But this is the capitulum right here. There's our medial epicondyle. Doesn't matter which side we flip the humerus, either way, it's fine. If it's lined up with the head of the humerus, it's the medial epicondyle. And the trochlea is right next to it. There's the trochlea and the medial epicondyle. There's the capitulum and the lateral epicondyle over here. So now we've got this humerus that fits into the glenoid cavity. And we'll see when we get into muscles that those tubercles, the greater and lesser tubercles, are the points of attachment for for two of those rotator cuff muscles. We've seen three of them already. Now, this next set of bones in the forearm are designed to give us great ability to manipulate our environment. There is no other bone in our body that looks like the radius. The radius has a round head with a neck. It has a radial tuberosity sticking up. It has a styloid process at the wrist end of the radius. And we have two more bones, with two bones after the two styloid processes in the skull. We see styloid processes on the radius, on both radii, and both ulnus. That's the other bone here. This is one of the two bones that have the most unusual shape or distinctive shape in our bodies. We have this round head here. You can't see it, but this bulge is the tuberosity, and the styloid process is down here, probably broken off. But when you look at this movement around here, you can sort of see the styloid process. Let's go here to another picture. There's our head, right there. The neck is this narrow area between the head and the radial tuberosity, which is right there. And the styloid process is down there. It's also, if you look carefully, you can see the bulge in the highlighted, see how the bone is highlighted. Look where the arrow hits on the bone every time it goes around. You can see the bulge that's sticking up. That is the radial tuberosity there. I don't know why I didn't label it. I'm supposed to label it. So anyway. Now, what does this do? Well, the radius allows us to turn our arm. Notice how the radius, this is the radius, this is the head of the radius. And of course, now there's the radial tuberosity. Watch how it shifts. You can see it when it flips around there. This is the head of the radius. The radius is going to rotate around the capitulum. That round head rotates around the capitulum. So when you turn your arm, you're turning your arm, the head of the radius is pivoting on the capitulum. Here's this, by the way, there's the styloid process there on the radius, and radial tuberosity again shows up here. So this is rotating. So when you turn a doorknob, when you turn a key, when you turn a screwdriver, when you rotate your arm, what you're doing is you're turning the radius around the capitulum. because that's the capitulum right there. This is still the trochlea over here, and the medial epicondyle there, and the lateral epicondyle there. So now here is another view of the radius. This gives you a better perspective on the head, the neck, and the radial tuberosity and the styloid process. So there's our radius. Styloid process, head, neck, radial tuberosity. You can see it highlighted right here. You can see where the head of the radius articulates at the capitulum right there. Now the bone next to it is called the ulna. This is the other bone that has a very distinctive shape. No other bone looks like this either. I always think it looks like a socket wrench. You can sort of imagine, have a little imagination. But this structure here is our elbow. If you place your fingers on your elbow, you're feeling the olecranon process. This is what that structure is called. The olecranon process is our elbow. And this is what helps us. By pulling on our elbow, we can move our arm back and forth. We have two bones here in our forearm. We have the radius and we have the ulna. The radius, let me go back here, one picture. The radius at the radial tuberosity, our biceps muscle, the muscle that sits on top of our arm, pulls on the radial tuberosity and causes our arm, if you want to bring your hand back to your shoulder, if you want to flex your arm and bring your hand back to your shoulder, you are pulling on the radius with your biceps. If you want to extend your arm, you are pulling on the olecranon process with your triceps. If you want to pull your hand flat out straight in front of you, you're pulling on the olecranon process. The elbow, you're pulling on the elbow. The triceps muscle attaches to inserts on the olecranon process. So you can stand there all day and move your arm back and forth, flex and extend. And you are doing that thanks to these two bones and the biceps and triceps muscle. Again, don't worry about the muscle. I'm just trying to make it a little more relevant to what we're talking about. So, but the olecranon process right there is your elbow, and you can feel your elbow. You're feeling the olecranon process. The coronoid process there, but more importantly, there is the trochlear notch, and this articulates over the trochlea. As the elbow moves, it will pivot over top of the trochlea. There is a coracoid fossa. I'm sorry, there is an olecranon fossa on the posterior surface of the humerus that allows this olecranon process to move into it as it rotates back and forth. So trochlear notch sits on top of the trochlea. And so we move our arm, we move our elbow by pulling on the ulna. The olecranon process is our elbow. We move our elbow by pulling on that with our triceps. So, and then down here is our styloid process. So now we know where our elbow is. What it's called the olecranon process. Let me go back here. I want to say one thing about the radius. There we go. Now, if you can find your thumb, you can remember a lot of things about structures in your body. Your thumb is on the radius side of your forearm. So if you know where your thumb is, the radius lines up with your thumb. So now you know where your radius is, because we can pretty much identify our thumbs. the radius lines up with the thumb. That means that underneath the radius, the bone that's underneath the radius is the ulna. Now, so now we know we know our thumb, we know our radius, we know our ulna. We know that the radius rotates around the capitulum and the ulna rotates around the trochlea, because there's the trochlea right there. There's the capitulum there. And we have the medial and lateral epicondyles. So now just by knowing that, we can see that first our arm rotates thanks to the radius. And we know that our elbow moves thanks to pulling on the olecranon process. We also know that our arm can bend because we pull on the radial tuberosity. So just by knowing where your thumb is, you know where your radius is and you know where your ulna is. And it's a very short leap of faith to know that the olecranon process is the elbow, and the radial tuberosity is that bulge there, and they articulate at the capitulum and the trochlea. In AP2, we're going to get into a little, again, knowing where your thumb is real important, because you can take your pulse at the radial pulse. It's location directly behind the thumb on your wrist, where the radial artery comes down along the radius. The radial artery goes down towards the hand and the radial vein goes back. Down at the ulna, we have the ulnar artery running to the hand and the ulnar vein going back. So with just knowing your thumb, you also know where the ulnar nerve and the radial nerve are located. So just by knowing your thumb, you know the location of 2 arteries, 2 veins, 2 nerves. You know the location, the insertion of 2 muscles, and you know that 2 bones that the ulna and the radius have to articulate on to make it work, just by knowing your thumb. Anyway, let's go on past here. Let's go to the hand now. This is our hand. We have 3 sets of bones in our hands. We have the phalanges, which are the fingers. We have the metacarpals, which are the bones of the hand itself. And we have the carpal bones, which are the wrist bones. Now, the good news is that our feet use similar names. The toes are called phalanges, just like the fingers are. That's good. The bones of the foot are called the metatarsals, and the important bones, I shouldn't say important, but they are the important bones, are the tarsal bones. So we have the tarsal, here we have carpal, metacarpal, and phalanges. In the foot, we're going to have tarsal, metatarsal, and phalanges. So carpals, metacarpals, and phalanges. Now, if we look at the hand, I expect you to be able to tell me phalanges, metacarpals, and carpals. I don't really go over, because of the shapes are all very similar and they're very difficult to identify on the bones of the wrist. I want you to remember that they're carpal bones. Later on, in advanced classes, you'll probably have a chance to learn the individual bones of the wrist. But for right now, I'm just going to run over with them for you. The trapezium, the trapezoid, the scaphoid, the capitate. I always think there should be a decapitate, but there isn't. The hamate, the lunate, the triquetral, and the pisiform. It's hard to identify these bones because not every one of these little carpal bones on a model, for example, don't play fair because a lot of them all look the same. So we have enough bones to worry about. So these are the carpal bones: carpal, metacarpal, and phalanges. There are the 5 metacarpal bones. Okay, now moving into the pelvic girdle, we're looking at what we see here is a female pelvis. This is female, for whatever reason, And these are models, they're not real, they're life-size models. Hand painted, handmade in Germany. They're very expensive. And for whatever reason, it's very difficult to get a female pelvis. I've been here 18 years, and we've gradually accumulated 2. All the other pelvis models and all the skeletons are male. I don't know why. That's just what we end up getting from the supply houses. So, but there are some very distinct differences. And the reason I emphasize that there's some very distinct differences in the female pelvic structure versus the male structure. Now, common bone here, this is called the ilium. We can find our ilium because there's an edge to the ilium called the iliac crest. If you put your hands down around your pocket region and start rubbing right about the midline of your pocket, you can feel a sort of a ridge or a bump. That's the iliac crest. That is the top of your ilium, a large flat bone on either side of the pelvis. So the pelvic girdle is made up of 3 different bones plus the sacrum and coccyx in here. So there is the iliac crest, good landmark. You know, the pelvic crest, the iliac crest is a great landmark for knowing where to make injections, particularly, you know, intramuscular injections that go into the hip, because we don't just stick them in our butt. There's a specific location where we try to aim for, and I'll tell you why here in a minute. There's the iliac crest. First, there's the sacrum, and below the sacrum is the coccyx. There's the pubic bone in the front. There are 2 pubic bones that come together, and they're joined in the middle by what's known as the pubic symphysis. You know, it's not a fused symphysis like the mental symphysis is. This is got a big pad of fibrocartilage in the middle. That's what this location right here. The second of the 3 bones that make up the pelvis on each side is the ischium. And so the pubic bone and the ischium fuse with the ilium right about the level of the socket here. The socket is called the acetabulum. Now, in the back, the iliac crest, the iliac bone or the ilium comes together with the sacrum to form the sacroiliac joint. Shock of motion is absorbed in the front. You know, it's transferred up the legs, up the femurs, into the acetabulum, and there into the bones. Now, in the front, the shock is absorbed here at the pubic symphysis. In the back, the shock of motion is transferred to the sacrum, through the sacroiliac joint here, and then up the spinal column, and where it gets absorbed by the intervertebral discs that we see here and further on up. Those discs are the shock absorbers that allow us to walk without pain, or at least how we're supposed to walk without pain. There's the pubic symphysis. It's that pad of fibrocartilage right between the 2 pubic bones. This opening here is called the obturator foramen. The obturator foramen, we have to have a passageway for nerves and blood vessels to move down into the legs. And so we have this opening called the obturator foramen that allows the large veins to come up the legs and go towards the inferior vena cava, and the large arteries to come down off the aorta and move down into the legs. And the nerves also pass through these openings. Lumbar vertebrae and intervertebral disc up there. This is the acetabulum. This is the socket. It's a deeper socket than we have with the glenoid cavity, but we have a bigger bone to deal with too. The femur, the head of the femur is much bigger, much larger than, much greater in size, as I probably should say, than the head of the humerus. This is the pubic arch. It's the shape of the curve across the base of the pubic bone, where the 2 come together. Now, in a female pelvis, the pubic arch is rounded like an inverted bowl. In the male pubic arch, it is shaped like an inverted V. It is a narrower structure. The female pelvis is designed for childbirth. The wider, broader opening, so there's more room for the passage of a baby through the birth canal and through the area formed by the pelvic girdle itself. The male pelvis is much narrower, and there is not the space inside it because babies don't come out of. There is no birth canal in the male structure. So this is the pubic arch. This angle here, again, like an inverted bowl versus an inverted V. Of course, there's this. Now let's take a look again. Some more here. The coccyx, yes. This is the true pelvis, the area from the wall to wall, the interior wall of the ilium on each side. The false pelvis is iliac crest to iliac crest. There's the false pelvis right there. The pelvic brim is the edge of this opening here that encompasses the true pelvis. And of course, there's the pubic arch again, and based on the structure of the pubic bones, is going to determine what the shape of the pubic arch is. If it's a female pelvis, it's going to be broader and shallower and wider, and like an inverted bowl, as opposed to an inverted V for the much narrower, shallower male pelvis. Okay, looking at the posterior surface here, we can see the sacrum and sacroiliac joint and the coccyx. Sacrum, ilium, ischium, pubis. Again, the pubic arch, the coccyx, the iliac crest up at the edge of the ilium, the spine of the ischium. Over here, we get a much better view of both the obturator foramen and the acetabulum, iliac crest. There is our acetabulum right there. And there is the obturator foramen right there. And next big important landmark to note on this is right here. That is the greater sciatic notch. The sciatic notch is the passageway for the sciatic nerve that moves from the pelvic region down behind your knee all the way to your great toe. It's the longest nerve in the body. It is probably as big around as your finger, made up of thousands and thousands of individual axons. And it is extremely sensitive to inflammation. So it passes through this notch here and goes on down there. Inflammation of the sciatic nerve is the root cause of sciatica in many older people, from constant pressure on the sciatic nerve. It's also why you don't give injections directly into the butt, into the gluteus maximus, because if you hit that nerve, it's a whole new experience in pain for your patient. So we use our iliac crest as a landmark to inject not in the gluteus maximus, but in a muscle called the gluteus medius. Anyway, now there's another notch here, a smaller notch called the lesser sciatic notch, because usually if you have a greater, you're going to have a lesser. The lesser sciatic notch is where a branch of the sciatic nerve, where the two branches come together. So that is that's most of our pelvic girdle. Of course, we have to have the other component here, and that is the femur, the largest bone in the body, because the head of the femur right here has to fit into the acetabulum. That's its socket. So here's our femur. There's the head. And just like in the humerus, the head is on the medial side. The head is always on the medial side. So everything lined up with the head is medial. Everything on this side of the bone lined up with the head is on the medial side. Everything on the opposite side is lateral. There's the head. There's the neck. The neck of the femur is usually where hip fractures occur. When people fall, and particularly older people, when older people fall and break their hip, they break, what they're doing is they're actually fracturing the neck of their femur, because that has become worn, it has become depleted of calcium over time, and it becomes fragile. So it doesn't take much to fracture the neck of the femur. Sometimes it's so fragile that a good vigorous sneeze or a cough can cause that to break. Now, usually occurring in elderly postmenopausal females. Why? Well, it's because the female hormone estrogen stimulates bone deposition, bone development. At menopause, estrogen levels drop off because the ovaries aren't functioning anymore. That's where the bulk of the estrogen is coming from. Estrogen levels drop. Bone production doesn't keep up with bone breakdown. Osteoporosis may develop. Osteoporosis is the breakdown of bone to get calcium. Well, one of the key areas for bone loss is right here at the head and neck of the femur. And this becomes almost like a target area for osteoporosis. And so grandma will trip in her kitchen or step off the sidewalk awkwardly, or maybe not, or just sneeze violently during the night and crack the neck of her hip right here. That's where most hip fractures occur. It's at the neck of the femur. We have a couple of bulges on here for points of attachment of some of the large muscles of the leg. We have what's known as not the greater tubercle, but here we have the greater trochanter. And that's on the opposite, just like the greater tubercle is on the opposite side of the head, the greater trochanter is on the opposite side of the head. That means this little guy over here is going to be the lesser trochanter. And we have this ridge here called the intertrochanteric line between the two, greater and lessers. Now, at the opposite end of the femur, we have a medial epicondyle, just like we did before. It's on the same side as the head. That means the bulge out here on the other side is the lateral epicondyle, right there, and that is the lateral epicondyle. The bulge, side-to-side bulge, are epicondyles, up and down are called condyles. Our femur is going to have both here. I'll show you here in a second. Medial epicondyle lines up with the head. So the bulge on this side of the femur is the medial epicondyle. That's the lateral epicondyle. Those are points of attachment for ligaments that help hold the tibia and the femur together. So you'll see that here in a second. Well, not notice it next to it. So, okay. Now, looking at the posterior surface of our femur, we still see the neck and we still see the head. There's the head. This is the neck right in here. This is the area that breaks easily in older people. Not everybody has that problem. You know, it seems to be more prevalent in postmenopausal older females that are experiencing osteoporosis. Greater trochanter, lesser trochanter. You know, lesser trochanter is on the same side as the head. We have the intertrochanteric crest now. It's a line across there. So if we go to the opposite end, the distal end of the femur, we now see the medial condyle, the up and down bulge. We still have the medial epicondyle on the side, but now we have the medial condyle lined up with the head. That makes that the lateral condyle. Now, the medial and lateral condyles are going to sit on top of the tibia. The medial and lateral condyles of the femur rest on the medial and lateral condyles of the tibia, the large bone of the lower leg. However, we have two pads of cartilage in between. We call those the medial and lateral meniscus. So, to protect the bone so there's no friction during movement. So we have the lateral condyle up here and the lateral epicondyle off to the side, and the medial condyle here and the medial epicondyle off to the side. So now here we see our femur, our patella, our kneecap. We see the most useless bone in our bodies, the fibula, because the fibula doesn't do anything. It's not a load-bearing bone. It doesn't do anything for us except form the outside of the ankle region. There is no ankle bone, by the way, just ankle region. So there's our fibula, and then the bone that does all the work in the lower leg is the tibia right there. That's our tibia. So this is the fibula. The fibula has a head and an ending called the lateral malleolus. There's the head, and there's the lateral malleolus. If you want to feel your lateral malleolus, reach down and touch the outside of your ankle. The outside of your ankle on the lateral side of your foot. The outside of your ankle is the lateral malleolus. That is the outer edge of your ankle. There is no ankle bone. You have a lateral malleolus and a medial malleolus, and they set on top or set adjacent to the talus. But there is no bone labeled ankle. We don't have an ankle bone. We have three bones that come together. Now, the weakest of those three are the fibula. The fibula is so weak, this is the leg, the bone that's usually broken during skiing. This bone usually snaps if you look at it funny. It doesn't do anything. It's not attached. It has no strong attachment there. It's held onto the ankle, to the foot with ligaments. It has one ligament that attaches it to the femur, and that's all. The other end. Anyway, now our tibia, the hardest working bone of the lower leg. The tibia has a big identifying landmark on it, right in the front. It's called the anterior crest. We call it our shin bone, but it's really the anterior crest. It's a sharp edge. You walk through your house at night, and we use it to discover tables that have been moved and things that have been moved in front of us that we walk into. Things that are right about tibia height. Walk into it, hurt our leg. Shin bone. But that anterior crest, very sensitive. Not a lot of skin covering it. That's why it hurts so much when we walk into things. So there's the anterior crest, the very front, the sharp edge of our tibia. There it is again, right along here. You can see, you can feel it on your leg. You can rub your hand across the front of your leg. That sharp edge that you feel is the anterior crest of your tibia. The inside portion of our ankle is the medial malleolus. If you have a lateral malleolus from the fibula, we have a medial malleolus from the tibia. This is the hard working side. It's a very strong bone. It fits on the inside. It lines up on the same side as your great toe. So if you're trying to get your landmarks, you're looking at a model of a whole leg model with muscles or just a skeletal model, and you want to get your bearings, just find the big toe. The big toe is on the always on the medial side, always, because you can't invert your foot over to make it on the lateral side. You can turn your hands back and forth. And sometimes your thumbs are on the medial side, sometimes they're on the lateral side because your hands turn at the wrist. Can't get that action with your foot. Anyway, there's the medial malleolus, the other portion of our ankle structure. there is the medial condyle and the lateral condyle. As I said, they correspond to the medial and lateral condyles of the femur. We have big pads of cartilage that sit there to protect those bones. There's the anterior crest again. And there is the tibial tuberosity, a large bulge here for a point of attachment of muscles. And again, there are the condyles here and here. Now on the foot, we have the phalanges down here. The toes are the phalanges. This is the great toe. Number one is the great toe. These are the phalanges. These are the metacarpals. I'm sorry, the metatarsal bones here. Phalanges, metatarsals, and then these are the tarsal bones. Now, these, you will have to know their names, but because they're much more important to us, at least well, they're not more important, but we can at least identify them. Now, three of them have the same name, or the same last name. There's the medial cuneiform, the intermediate cuneiform, and the lateral cuneiform. There's the medial cuneiform there. There's the intermediate cuneiform in the middle. We see a lot of this in the middle stuff. We call it intermediate. There is the lateral cuneiform. Behind the first and second, behind the medial and intermediate cuneiform, we have the navicular, and over here we have the cuboid behind metatarsals 4 and 5. But we have saved the best for last. We also have the talus and the calcaneus. This is the talus. This is the bone that sticks upward on our foot. This is one of the tarsal bones that projects upward, and the medial and lateral malleolus are found on either side of it. The medial malleolus is on this side here, on the medial side, and the lateral malleolus is over here. And this bone that sticks out in the back is our heel bone, or more properly called the calcaneus. That's the point of attachment of the Achilles tendon, the tendon that controls whether or not we can raise or raise or lower our foot. So again, these are the phalanges up here. These are the metatarsals here, and these are the tarsal bones. We can see the medial cuneiform, barely see the intermediate cuneiform. You can see the navicular right there. And we see the talus. The talus projects upward here. This is not the navicular. This is the navicular over here. This is the medial malleolus from the tibia right here. The lateral malleolus is on the other side. This is the talus, and this one is the calcaneus right there. So, because the talus nests down in between the medial malleolus and the lateral malleolus, and it's the cuboid. Almost forgot that. And that is everything on the appendicular skeleton that we need to know. So let me stop sharing. Anybody have any questions on this? I managed to keep you all awake, I hope. So I know it can be sometimes it can be pretty dry. So anyway, if you don't have any questions, or you think of something later on, shoot me an email and I'll be glad to answer it. Otherwise, I'll get us out of here, and I'll see you all next week.